Welcome to Dirtyberg, where training is continuous. I'm JT, and this is Chalk Talk. Today, we are talking about the Q wave. The Q wave is any negative deflection that precedes an R wave. Q waves represent normal left-to-right depolarization of the interventricular septum. Septum between two ventricles receives Purkinje fibers from the left bundle branch, and therefore depolarization proceeds from the left to the right side. And it's usually seen in all leads, except for V1 to V3, because of where they are placed directly in front of the septum. So they don't see that movement the same way the other leads see the movement of depolarization. For example, V5 through 6 are way over here to the more lateral side, and from their point of view, the electrical movement is running away from them, so we get a negative deflection. Because we remember that electrodes produce positive deflections when positive currents are coming towards them, not away from them. Now, in times where we don't see any Q waves present in V5 and 6, we need to know that it's usually due to a left bundle branch block. The reason is with that bundle down and not allowing its intended pathway for depolarization to occur, much like if a road was shut down, the vehicles, or in this case, a positive current, would have to find another route to get to its destination. So, there would be no left to right travel right here. It would have to start depolarizing the right side first, and then go through the left side by taking a scenic route. So, we know we should see Q waves in most of the leads, except V1 through V3. That's the first sign of our Q waves not being pathological, which is almost always a sign of infarction or previous infarction. It is crucial for us to be able to differentiate between normal and pathological Q waves. And typically, we want to see what we think are pathological Q waves in at least 2 contiguous leads. The same rules as ST elevation, because we are analyzing different regions of the heart shown here. So, first sign of normal Q waves that we don't have to worry about is not seeing them in V1, V2, and or V3, so long as they are placed correctly. The picture we get is only as smart as we allow it. So, if we were just throwing stickers at the chest to where it kind of looks right, we are wasting everybody's time. And, as the saying goes, time is muscle, so be better. Every electrode has an anatomical location where it is to be placed. The second sign of us having normal Q waves is they are less than 1 small square. We'll stick to the little boxes on the ECG strip instead of millimeters to make it feasible and easy to detect. Number 3, they are less than 2 small squares deep. And lastly, they are less than 25% the depth of the entire QRS complex. Basically, not taking up 1/4 of the size of the whole QRS or larger, then we don't have to worry. I also want to show some attention to a few other things. R waves may not always be present in V1. Because of this, we may only have a negative deflection as a QRS complex. We can't tell what is Q and what is S. So because of this, it's termed a QS wave. That can be a normal finding in V1. However, if we also see this in V2 and V3, again with normal electrode placement, it could very well mean a current or prior myocardial infarction. Lead 3 gives us an interesting variability to its Q waves. We call them respiratory Q waves. The fibrous pericardium of the heart is firmly attached to the central tendon of the diaphragm. So because of where lead 3 is located when the diaphragm is relaxed and not contracting downward, depolarization is pointing directly at lead 3, versus when we inspire, the diaphragm contracts, tugs, and shifts the position of the heart in the chest. This can also change with position of the patient. Are they supine? Are they sitting upright? Are they stuck upside down on an inversion table, complaining of chest and head pain? That last one, we'd recommend just getting them down first, by the way. But because of the shift in the heart, we call these changing Q waves respiratory Q waves. One example of Q wave findings is in S1Q3T3 for core pulmonale issues. But we'll talk about that one another day. So, to sum it up, the Q wave is depolarization of the interventricular septum. Septal Q waves are small Q waves frequently seen in the lateral leads, V5, V6, AVL, and lead 1, and usually V4. Respiratory Q waves can change in lead 3 based on position and ventilation of our patients. V1 will sometimes have a QS complex if no R wave is seen due to its location on the chest. V1 through V3 should never display Q waves. They should be smaller than a box, and they should not be at or greater than 1/4 the size of the entire QRS complex. Thank you for tuning in. Hopefully this helped you understand a little more about what's going on beneath the Q wave. In next week's Chalk Talk, we'll be discussing the R wave.
Don't forget to like and subscribe.